I do see more people are joining, but I guess in the spirit of everyone's time and to stick to the hour, I guess we'll get started. So welcome everybody. My name is April Feld. I'll be leading or moderating our wonderful panel today. Our topic presented by YNAA is Living to the End, Embracing Humanity's Life Transitions. And so with us today, we have three experts whom I will introduce in just a minute and thank them so much for volunteering their time and energy to be with us tonight in talking through this really important topic. So because I can't memorize it, I am going to read to give you a brief intro of our panelists. So we have Elyssa Noce. Elyssa is an adult gerontological primary care nurse practitioner and a 2017 graduate of YSN's MSN program. She has over a decade of nursing experience working with patients with chronic conditions and is now a nurse practitioner within the section of nephrology at Yale New Haven Hospital, where she provides care for patients with both advanced chronic kidney disease and stage kidney disease and on dialysis. We also have Shelli Fetter. Shelli is an assistant professor at the Yale School of Nursing, an NIH-funded investigator and health service researcher who investigates ways to increase access to high-quality palliative care for people with non-cancer serious illness, and is also an advanced certified hospice and palliative nurse with over a decade of clinical experience in the field. And lastly, tonight we have Caitlin O'Day. Caitlin is a licensed clinical social worker and certified case manager with over a decade of experience spanning the continuum of care, the hospital, post-acute sector, as well as more recently, the community-based care ambulatory setting. Caitlin is an expert in discharge planning with attention to level of care and has also trailblazed the advanced illness management model of care for Stony Brook Medicine's clinically integrated network care management team. So with that, thank you again all for agreeing to be here tonight, and we shall get started. So I think Shelli wants to open us up with a quick PowerPoint just to have a great overview of hospice and palliative care. I'm turning it over.
Also talk about the state of the science and the state of palliative and hospice care in our clinical practice. So what is hospice and palliative care, and what is palliative care? So when we talk about palliative care, we're really talking about specialized medical care for people with serious illness. This is care that's focused on providing patients with serious illness relief from symptoms and stress, regardless of the diagnosis. And I just want to emphasize that point, that it's regardless of the diagnosis, whether it be cancer, end stage, renal disease, heart failure, which is my specialty, or dementia. Palliative care is appropriate for any person with a serious life-limiting illness. It is also an additional layer of support. And I say this a lot to my patients. As a palliative care provider, my job is to provide additional supports, whatever that means for the patient and their family. It may mean symptom management. It may mean talking about goals of care. It may mean connecting to hospice, but we as palliative care providers are intended to provide services in conjunction with the patient's primary team, as well as other specialists. What is not palliative care? And I do talk a lot about this with my patients. So we are not the Grim Reaper service, as oftentimes as our patients would think we are. It has happened more than once that I walk into a patient room and I'm met with a frightened patient who thinks that I'm there to talk about hospice and who I'm there to talk about end of life, and they don't want to talk to me or meet with me. Palliative care specifically is not the Grim Reaper service. We do talk about goals and wishes and desires, and we do focus on patients with serious illness, but we don't just provide end of life care. We are not only for patients with cancer, we are, as I said earlier, we are for patients with any serious illness, and we are not only for patients who are at the immediate end of life. So when you refer patients to see palliative care, what is it that we actually do? And so we wear a number of hats. You can see from this diagram that there's a number of things that palliative care helps with. We help with physical and psychological symptoms, including pain, anxiety, depression. We help with connecting to services. Sometimes that means connecting to social services, caring for caregivers. We provide spiritual support, so we often have chaplains on our teams. We help patients navigate ethical and legal issues, things like most and post forms, advanced directives, healthcare proxies. And then we do often connect people to hospice care as they near the end of life. We also finally provide culturally competent and tailored care to our patients and families. In general, palliative care, the focus of our services is really holistic care for people with serious illness. This figure gives you an overview of what the palliative care to hospice care trajectory looks like. And I show this in part because I think when people think about palliative care, they often think that it's appropriate for people who are within the last 6 months of life. And the truth is, care at the last 6 months of life is typically for people who are on hospice care, people who have a less than 6 month trajectory. Palliative care is really appropriate for any patient with a serious life-limiting illness. There are guidelines that tend to be condition specific that dictate when palliative care should be involved. So for example, for people with stage 4 cancer, typically people with who have stage 4 cancer will see palliative care, whether it be heart failure. Typically, if you have advanced heart failure, the guidelines recommend consultation to palliative care. So it just kind of depends on the condition. But as you can see, once somebody with a chronic illness starts to have additional complications, their chronic illness becomes more advanced, then it's time to start thinking about getting palliative care involved. This figure shows that that palliative care, that the palliative care trajectory doesn't simply end with a single consultation. At least that is not the intention. And for most members of our team, the goal is to follow people over time. We as palliative care providers do our best work when we have a long-standing collaborative relationship with our patient populations. And so what these two figures show you are the involvement of palliative care over 2 different illnesses, whether it be cancer or stroke. And you can see that involvement of palliative care may differ depending on what the patient's primary diagnosis is. For cancer, we may get involved, once if cancer is diagnosed at stage 4, and then, once they, finish therapy, we may take a step back and then come back, and care for the patient again as this disease progresses or if symptoms worsen. For stroke, again, in the acute phase, we may be involved, and then there may be a lull where we're not necessarily involved until the person develops more complications. So it just depends on their disease trajectory. I want to switch gears a little bit and talk about hospice, because hospice is distinct from palliative care. It falls under palliative care globally, but is a distinct service in a number of ways. This is compassionate care for people facing a life-limiting illness or injury. It's team-oriented and interdisciplinary, and it comes from the notion that everyone deserves to die with dignity. It's typically limited to people with a terminal diagnosis of 6 months or less, and it is a medical benefit. When might a patient be ready for hospice? Well, because it's a medical benefit typically provided by CMS, there are guidelines, and here are some criteria that we tend to look for when we consider whether or not somebody is ready for hospice. Again, they have to have a life-limiting illness or 6 months or less, but these are some of the other criteria we look for. Do they have a rapid progression of their disease? Is it non-reversible? Do they have non-reversible weight loss or declining serum albumin? Do they have increasing dependence, dysphagia, low blood pressure, increasing ED visits or hospitalizations, multiple pressure ulcers, falls, or recurrent infections? There are certain eligibility criteria for hospice. Somebody has to be generally entitled to Part A of Medicare, and they have to be certified as being terminally ill by a physician. This can be a hospice medical director or physician member of the hospice interdisciplinary team. And they have to be certified as having a prognosis of 6 months or less. And then essentially a patient signs a statement choosing hospice care over other Medicare covered benefits. Now, I just want to reiterate this point in that currently only a physician can certify that a patient is terminal or has a terminal diagnosis of 6 months or less and authorize hospice care. Nurse practitioners can recertify hospice eligibility and bill as attending physicians in hospice. But again, at present, only a physician can certify terminal diagnosis. Now, There has been legislation proposed to change this. HR 8812, the ICAN Act, was introduced in September of 2022. Among its other provisions, one of the primary pieces is to allow for advanced practice providers to certify that a person is terminally ill for hospice eligibility. So this figure shows the state of palliative care, given, wherever you are across the United States, you can see where your state lands in terms of access to palliative care. So this is of hospitals with 50 or more beds, how many offer palliative care services. And you can see the majority of hospitals are graded in A or B. If you work in a hospital or hospital system with 300 or more beds, 80% of those nationwide offer palliative care services. Regarding the state of hospice, unfortunately, access to hospice and timely access to hospice specifically is somewhat condition dependent. Still, even though this benefit has been available since the 1960s and 70s, people are referred late to hospice, often within the last week of life, sometimes within the last 3 days of life or less. And referrals to hospice tend to be better for people with cancer because, oncologists, oncology providers tend to be more comfortable with referring patients with cancer to hospice. Access to hospice and referrals to hospice tends to be lower for people with non-cancer conditions. So people with heart failure, people with COPD, dementia, these people tend to be referred often late. And so that is it for my intro, and I will hand it back over to April.
Yes, thank you. So I wanted to go back to a few points that you brought up. So thank you very much for clarifying hospice versus palliative care. I think it's the first step in this conversation. I think what I want to hear more of is, we know that hospice is underutilized, certainly by the last bullet, which was less than 1 week into hospice experience, patient ends up dying, or sometimes even less than that. That's evident in itself. But can you talk a little bit more about the storyline with palliative medicine in terms of access to that and adoptability of that? Are patients transitioning to that easily? What is the feeling like in the community setting? What is your experience?
So specifically access to palliative care?
Yeah, as a bridge to hospice potentially, do you find that patients actually are more willing to take it on, or there's still stigma? What is your experience?
I think unfortunately there's a lot of stigma around what palliative care is and what they can provide. I think primary care providers, right? Patients' primary care providers and specialists really set the tone for when to get palliative care involved, and really, frankly, when to get hospice involved. If they talk about these services as something that is to be frightened of, or something that is, when everything is tried and there's nothing else left to do, then patients are less likely to want to access palliative care because they're concerned about giving something up. So it's all about how these services are discussed with patients and their family members. And the most helpful, most efficacious ways to have these conversations is to do so frequently. When a patient has a chronic illness that is progressing, that is, becoming more advanced, primary care providers and specialists really should introduce these concepts to the patient and family early, so that when it comes time to refer patients to palliative care and refer patients to hospice, it doesn't come as a shock. Right,
of course. And as a little bit of a tentacle to that, do you think the community of practitioners is actively seeking palliative as a track for themselves, or do you think there's limitations around that? Can you talk a little bit more about that in terms of a provider service?
Absolutely. So we desperately need advanced practice providers in palliative care. I'll say it again, we desperately need advanced practice providers in palliative care. I think, it's increasingly we see residency programs that are popping up that train, new grads or even people who are switching specialties into palliative care to become advanced practice providers, specifically focused on palliative care or hospice. There is a fairly dire workforce shortage. In palliative and hospice care, the population in the United States is aging. More and more adults are living with serious chronic illness. And so it's estimated that the palliative needs of people with serious illness are only going to increase over the next decade. And yet we have a situation where workforce is not available, cannot meet demand. And so I think there's definitely a need for more workforce. I think there is also a need for more training programs, whether it be within schools of nursing or hospital-based, to train advanced practice providers to become, palliative care specialists.
Excellent. Thank you for that. So I guess that pivots us a little bit in that if there's a shortage, generally speaking, that means like this is an interdisciplinary conversation. It always has been. And perhaps others, not just nurses or doctors, are having these conversations. Let's talk about having the conversation, and then we can certainly come back to the current state of day-to-day practice in the hospital setting, in clinic setting, and what have you. So Caitlin, this goes to your domain. What can you describe for us what it's like to have these conversations? The circumstances in which they pop up. I know we always want to be proactive about it and have them early on, but we know all too well that doesn't happen enough. So what are the realities today?
Thanks, April. So right now in the healthcare field, conversations are happening usually at 2 times in a patient's life. And that's usually when they're at a crossroads in their health. So they found out they have cancer, or they found out they might need dialysis. And they're trying to figure out what the plan is going to be. So we have those conversations. You can have a more conservative or palliative approach, or you can go forward with chemo or dialysis. And those tend to be a bit less sensitive of the conversation because the patient has more options. It's less urgent, and it's easier to have those conversations because you're giving the patient one good option, which is chemo and treatment, and the other option, which is palliative. So that's a time when this happens a lot, right? Because we have to have that conversation. We have to give them these 2 options. The other time that these conversations take place is when all of the options for patients' treatment have been exhausted without any positive results. So maybe they've done all the chemo, but the cancer's not getting better, or they have an acute event and they're in the hospital, and it's really an urgent need to decide whether this patient will need a trach or a peg, or are they going to live on a vent long term. So those right now are the 2 most used times for palliative care, especially in the inpatient setting, because that's when we see a lot of decisions being made. So right now, that's really when the conversations are happening. And the goal of these conversations is the same. We want to find out what the patient's wishes are, what the families have already discussed with the patient. But these conversations can feel very different due to the urgency needed to make the decisions. And, they can be very difficult for practitioners to have if they are not already seasoned in this palliative care and hospice conversation. So that's really a big barrier to the conversations coming up in general, is that any of the clinicians are not comfortable having the conversations. They're not used to having these conversations. And, our goal is always to do what's best for the patient. We always want to give the patient the best outcome. Most of our patients have hope and they want to live and they want to get better. But the reality is that might not happen for everybody. And we have to be realistic in having these conversations. And it can be very hard to do that when you might not have options for the patient. So I think the biggest thing that I've learned is starting where the patient is at and having those conversations by starting it with, what do you know about palliative care? What do you know about hospice care? And starting where the patient is at, so you can give them that education before getting into it and not coming at them with, this is these are your options, you have to choose something, but really educating them to their options and discussing palliative versus hospice, because a lot of times palliative and hospice are lumped together, and people hear palliative and, you know, they think hospice and they're like, no, this is not the time, I'm not ready for that. So I think education is one of the biggest things we can do as practitioners, is to educate our patients, educate each other, people who may have not had these conversations with patients before, and have these conversations together.
Thank you for that. What about, I hear that you say a big barrier for clinicians at any level is maybe comfort and experience or exposure to it, plus like the training behind all that can support that. What do you think are top barriers for the patient and family? Like, can you walk us through some of that?
Yeah, absolutely. I think, as we discussed before, it's the stigma around hospice and palliative care. You know, the old school thought of hospice is, you know, like Shelli was saying, the Grim Reaper, you know, we're here to just put everybody down, but really they don't understand. So I've talked to many patients and families, and as soon as you mention the word hospice, the guard goes up and they don't want to talk about it. They don't even want to hear about it. So it's really hard to get past that if people don't have that experience already. And, you know, a lot of people feel that they're giving up, or they're giving up on their loved one when you mention hospice. So, you know, that's why education and having time to sit down and really explain everything to families and patients is so important. And that's where we're missing out, I think, right now in the healthcare community, because the conversations are happening at these imminent times, but really we're lacking the conversations with the patient who has a chronic progressive disease, such as CHF or COPD. You know, we're waiting until they're in this acute phase to discuss these things a lot of times. So what we really need to do is step back and start this earlier, when they first get these diagnoses. And it's hard and it's sensitive, and people don't want to have these conversations, the patients and the families don't, but it's good preparation for the future, because they are chronic progressive diseases, and we need to think about this so it's not an urgent situation.
That's great. That is so awesome. I can't help but try to envision myself in having one of these conversations and like trying to compartmentalize my own thoughts and emotions. How do you do that as a caring provider? How do you connect with the patient and family, respect the decisions in the room, the feelings, the attitudes in the room, and maintain your composure? Is there anything that you can say about that?
Absolutely. And like I said before, I think starting where the family is at. So, you know, I've done this conversation many times, but it's probably the first time for a lot of these people. And I think getting their feedback first about what they know about the prognosis, what they know about hospice and palliative care, starting with that can make it a lot easier for yourself, and knowing what to touch on and what areas to talk about. And then also knowing a lot about hospice and palliative care and how much they're going to get out of it makes it a little bit easier to have those conversations, because, you know, I know that people on hospice really, after I talk to their families afterwards, after the patient may pass, they've all had a great experience. So knowing that giving them this option is really giving them the dignity to die in peace, die with dignity, and make those decisions. And knowing that this is a good option for them makes it a little bit easier. But it's always hard. It's hard for the practitioners, especially when you're deeply involved in the cases. And just knowing that you're there to support them and educate them, and you are giving them the options of the best outcome for them.
Seems easier said than done.
Absolutely.
And it does sound like it takes practice and patience.
Mm-hmm.
So let's get to more of real world examples. I think people can really relate to that. And this is where I'm going to call upon all of your experiences between Elyssa, yourself, and Shelli. So Elyssa, can you lead us off with maybe some defining moments in your current practice, or maybe prior, anything that you'd like to share that we could really latch onto and learn from?
Sure. So I like to look at what I do in managing chronic kidney disease is kind of like encompassing a lot of primary care principles, mostly just because, chronic kidney disease is a chronic condition. Most patients have diabetes or hypertension, which are very, very common comorbidities in the US. And so there's a lot of management that involves like all three things in some way. And so we've talked a lot about how some diagnoses are easier to address because there's like widely accepted knowledge that there's a clear outcome, right? If you have cancer, if you don't do the chemo, then the result is going to be death. It's a little bit more clear to the general population what that outcome will be. And I think it gets a little trickier when you're talking about some of these conditions that decline more slowly or aren't as obvious in terms of like what the outcome will be. But they're still progressive in nature, and the result can be a devastating diagnosis, even if the initial diagnosis doesn't have that devastating effect. So some of these things, like I mentioned, are like diabetes or hypertension or chronic kidney disease, where they may not be considered devastating in the beginning, but they do actually have an end result that is terminal. So longstanding hypertension leads to cardiomyopathy, it leads to heart failure, heart attack, stroke, like all these things that we know are end results of untreated hypertension. Similarly, longstanding diabetes has micro and macrovascular complications, including heart attack, stroke, kidney failure. Aging itself is a physiological process that's progressive in nature. And so these are all things that we don't really think of as acute illnesses that prompt that conversation about palliative care, because by the time they actually reach the end, it's actually too late to even have that conversation and the trajectory. Like as Shelli pointed out, like you shouldn't be waiting till the last 6 months. It's had the acute diagnosis of hypertension, 6-10. So I like to think of the conditions like diabetes and hypertension and aging as progressive. So there are so many opportunities to actually discuss palliative care options, the options of no treatment, the options of what happens if you do progress to a devastating diagnosis so early on. As Shelli mentioned, people don't do this very well. Caitlin emphasized that people don't do this very well. I again will say I don't always do this very well, even when you intend to do it. These conversations are a place where we are consistently missing the mark as providers. So in my own personal practice, I take care of patients with chronic kidney disease. So this is a progressive, irreversible condition. It results in organ failure. You cannot live once your kidneys fail. It is one of those conditions where you have treatment options. So you can have dialysis, you can get a kidney transplant if you're eligible. You can also choose the option of no care, or no treatment, which again means that is the terminal diagnosis, and that is you cannot live once your kidneys fail. That option is very rarely actually presented to patients in routine primary care or even in specialty care. Very few people actually set out and say, oh yeah, we have this dialysis, we have transplant. Very rarely are we saying, and you can also choose not to pursue any of these options. Very rarely do we say, hey, what do you want as the option? It's more of, here are your options. So I think in medical care, a lot of this chronic disease management is just so reactive. Their A1C went up, you increase their insulin. Their blood pressure is not at goal, you add an additional therapy. So when I kind of step back and I think about these things from a palliative care lens, I actually think about the fact that a lot of management of chronic conditions is actually primary prevention for some of those more severe consequences. So you kind of lose that, but management of chronic care is truly trying to prevent that devastating result that happens when it's untreated. So you treat hypertension to avoid that heart failure. You treat diabetes to preserve limbs, to preserve kidney function. And you want to reduce that risk of heart disease. The end result of all of these chronic conditions is actually that devastating diagnosis, like heart attack or stroke, where again, we're reactive. And now this is the point where we're discussing palliative care. Now that you may have hemiparesis from your stroke, or you had a heart attack and you're intubated in the ICU, and then it takes a long time to recover from a traumatic brain injury or an anoxic brain injury from being down during a code. I don't know if anybody has mentioned it before, I may have missed it, but the success of CPR is actually really low. So, and there are severe consequences to undergoing CPR for a lot of patients. So this is why, like, I feel really strongly that in reality, in these chronic conditions, you have to talk about these things early before you have that progression to a terminal or to a devastating diagnosis. So as I mentioned, like when I talk to patients, I talk to them almost daily about dialysis options. And I myself am guilty of presenting them as like, here are your three choices. We have hemodialysis, peritoneal dialysis, or kidney transplant if you're in that eligible age range. Very rarely do I find myself even saying, but you know, if you don't want treatment, it's okay. This does come up in conversation quite often because a lot of people will be like, nope, I'll never do dialysis. And it's almost like, it almost ends up being like a little bit of a threat. Well, if you don't choose one of these, you do know that once your kidneys fail, you die. So like reframing those conversations is really kind of a challenge with patients. And it's where some of this like palliative care conversation earlier on is so handy. It shouldn't be when a patient has stage 5 chronic kidney disease. It's the first time that they're being introduced to the fact that CKD is a terminal diagnosis. Untreated hypertension can lead to heart attack or stroke. This isn't when we have these conversations. It needs to be earlier on when changes can be made. Or the patients have the ability to make those decisions for what happens if they were to have either a non-fatal or fatal, devastating diagnosis pop up. So I think we as providers are kind of like trained to do whatever we can to help our patients, and we try to keep people alive. And sometimes that's actually not the service that's
gets in the way.
Patients. So I have a couple of examples of, devastating things where, we had opportunities to talk to patients, but didn't go through it. And they are all related to dialysis options just because of the nature of what I do. But an example, actually, I was just telling the group today, one of my patients who I've been taking care of for several years, she has been very clear. She does not want dialysis. We've probably been talking about her kidney failure for probably about a year or two. And she has consistently said, no, I don't want dialysis. No, I don't want dialysis. I understand. She has had heart disease. She goes into the hospital for chest pain. They offer her a heart catheterization. She says no, because the contrast could push her over into kidney failure. This has been something that's been very clearly documented for a very long time. Unfortunately, she had an MI this past weekend. She went into the hospital. Nobody ever did a DNR with her. So she ended up getting CPR. Her family called EMS. She's still in the ICU. They started dialysis on her. And so now she's trapped in a hospital bed undergoing treatment that she didn't want. And it has been very clearly documented in the medical record, but at the end of the day, it was not in writing and everybody did what they were required to do. And the family made the choice to treat her. So now her choice for no treatment was actually taken away from her. Similarly, I've had other patients where they get to kidney failure and they don't understand that they actually can't live once their kidneys fail. And so again, it's one of those opportunities where, they had chronic kidney disease for 10 years and nobody ever explained well enough that the patient understood what the outcome was. And unfortunately, this patient had a seizure. He had said he didn't want dialysis in the weeks leading up to the point where he had the seizure. And as soon as he was in the emergency room said, you know what, he's post-ictal, he's not competent to make his own decisions. And his wife chose to dialyze him. He ultimately had a stroke during his admission as well. And now he has very severe right-sided deficits. He was right-handed. So now he can no longer drive. He can no longer write. He has trouble feeding himself, but he's undergoing dialysis 3 times a week, when in reality, like he had said very clearly, I could have made this choice to not be treated and to get the appropriate care early on. So these are the points where we really failed the patients by, one, not having that conversation clearly enough, 2, and not documenting and making it like
the paperwork
document. Yeah. So like and I have so many issues of this, so many examples of this. And similarly, when people want to come off dialysis, like I have had people who are, have had bilateral above the knee amputations, multiple finger amputations, they're living in a long-term care facility. Like they're just kind of existing. And yet they are brought to dialysis 3 times a week because, they say, I don't want to come. And their family members say, nope, they're not capable of making that decision. And they continue to be brought to dialysis 3 times a week. And it's like that right to say no is kind of stripped away. And so again, like when you think about the chronicity of these things, it wasn't a surprise that like all of a sudden we reached this point. This was a very progressive process that took place over several years at minimum. And there's just so many missed opportunities for providers in general to get to that point. And the last thing I'll say is that one of the big things that we really talk a lot about in adult and geriatric medicine is like the 4M model, which in terms of like how we take care of patients. In the case of anybody's familiar with it, you know, we look at medications, mentation, mobility, but the most important piece is what matters most. And that's the piece that we often miss the mark on with patient care, is like, it's really about what matters most to the patient. And if they want to live their life in a certain direction, like we are there to help them with that, not necessarily impart our own biases on them or our own goals of care onto them.
Wow, you just totally blew me away. It's just so second nature and organic to you to like come up with these examples, because you're truly living and breathing the daily experience. I can't thank you enough for that, and to be really honest with how that looks and how it feels, where it's very frustrating when you can predict something and you wish it goes a certain way and the family and everyone's in alignment, only to find out that things got in the way that are beyond your control. Shelli or Caitlin, do you have any specific examples that you want to bring to light? And then we can circle back on other topics and questions. I believe there are 2 other comments that we can go to in the chat.
Sure. I mean, I think so. Oftentimes, I don't have a very specific patient in mind, but I do have sort of what has helped me to have these conversations and discuss, you know, transitioning to palliative and hospice care when a patient is appropriate. And I think, as Elyssa mentioned, the key thing is that this is not a one-time conversation. These conversations should occur multiple times during multiple visits, preferably, you know, in collaboration in conjunction with primary team and the family. And I think that is sometimes a barrier, I think, to having these conversations for people who are not palliative care specialists, because they take time. They take a lot of time. And while you can bill for advanced care planning conversations, right, there are CPT codes to do that, you know, most providers simply don't have the time in their day to have these conversations. So recognizing that this is not a one-time conversation. I think the next thing is to, particularly for people who have chronic conditions that are not necessarily cancer, is to understand what the patient knows about their condition and how they feel about it. More than once, I've been surprised by a patient who has told me that, you know, on their 9th heart failure readmission in the past 2 years, that, you know, they know that they're coming to the end. They don't want to be hospitalized for heart failure anymore, and they've said it, you know, they come out and say it, like, I don't want to do this anymore. You asked me what I think, this is what I think, I don't want to do it anymore. And that actually directs the conversation, right? So I think asking your patient, you know, what is it that, how do you think things are going for you? How do you think your disease is going for you? How are you feeling? Like, what do you see as your goals are in the future for this? And what is it that you want? You know, what do you want out of this care going forward, knowing that you have this very chronic condition, knowing that it's progressive, right? How have these things been for you? And I think often you can be surprised by what patients really understand about their condition and what they want and don't want in their care. And that really helps to guide the conversation. And then I think finally, for people who aren't palliative care specialists, but even those who are, you know, there are a number of resources, and I think we were supposed to talk about this a little later, but I'll jump the gun now.
Go ahead.
There are a number of resources that can help, you know, clinicians have conversations. One is Vital Talk, and they have sort of a figure that they call remap, right, which helps to guide like how to have goals of care conversations when you have a person in front of you with serious illness and you need to talk about what their goals of care are. And it stands for reframe, expect, map, align, and plan. Essentially, this helps you kind of walk through the steps with having a difficult yet crucial conversation. And this could be, you know, are we going to talk about, you know, comfort care? Are we going to elect, you know, DNR? You know, are we thinking about transitioning to hospice? And REMAP really helps you to navigate those conversations, right? So you ask the patient what they know about their condition and reframe for, you know, and emphasize that what is happening isn't working. You provide them with, you know, very concrete information about their condition, right? Whether there aren't any more treatment options, their condition is progressing, it's now advanced, and then you anticipate and expect and allow for that emotion for the patient. Then you map out what the goals are for that patient with this new information and align your care goals to that. And then you make a plan. And so there are very sort of concrete steps that are part of Vital Talk that can help clinicians to have these difficult conversations. One final piece, and I do want to emphasize that this is that oftentimes as clinicians, we use terminology to talk about things that are not very helpful for patients and their families. And one example of this is when we talk about you know, whether somebody should be, you know, should elect comfort care, and we talk about DNRs, and we ask the patient, and I've seen clinicians do this, I've seen, you know, residents, fellows, attending say, you know, do you want everything done? You know, in the case of a cardiopulmonary arrest, right? Do you want CPR? Do you want life-sustaining treatments? Do you want everything done? Now, any patient or family member might hear like the statement, do you want everything done? And say, of course I want everything done for my family member, right? I want them to, you know, to receive the best medical care. So we need to be careful about how we state things and instead rephrase that, do you want everything done, to, you know, given your severe illness and, you know, all of your other comorbidities, we recommend allowing for a natural death. We do not feel that, you know, cardiopulmonary resuscitation is the best option for you, and here's why, right? And so it's about emphasizing that, you know, the condition that the patient has, the severity of their disease, and then what options are available for them, what you can provide to them, even if that means they're transitioning to comfort care or palliative care.
Thank you for that. Before I go to Caitlin, just like a pause on what would you say, and all jump in, where does health anxiety and fear play a role here? Can you touch upon that at all? How does fear play a role in anyone's decision or lack of a decision? And what about anxiety management? Because these are real things.
Yeah, I think a lot of the fear that comes into these conversations is actually the unknown, and on both sides, right? So like providers have a hard time having those conversations because they don't know how to answer questions. Like some of those questions that Shelli was just saying, like those things are really complicated to address with a family that's upset, that's like looking at you for answers. From the patient perspective, not knowing is like the scariest thing out there for some of them. Similarly, like when we talk to them, not understanding what we're actually saying is also very scary for people. Fear itself lends to a lot of anxiety, and you kind of have to find the thing that works with those individual patients and really kind of do a lot of like teaching back, like, or like repeating, demonstrating that they understand, and really going back and forth. And it, like, that's not a one-time conversation. Like I think we've talked, it takes a lot of time to get through some of these topics. And I think I feel very strongly that, you know, education, I mean, it's the nursing side of me, like educating patients and really working with them is the most powerful tool that you can give them. The knowledge to understand that the decision they are making is what they really want is going to be the thing that will help irradiate some of that fear a little bit. I myself am a very anxious person. So when people tell me things and they don't understand, it's like, oh my gosh, I have to figure this out right now. And so it's very easy to like shut things off when you get nervous, anxious. You also have to be very cautious of working through people's different defense mechanisms. Like some people turn to humor. So sometimes like saying that, oh, here comes the Grim Reaper may truly be because like, I'm afraid of this service, or it might just be like, I am so nervous about what you're going to tell me that I am trying to laugh about it to make myself feel better. And like, you kind of have to like pick through emotions and really meet people where they are.
I couldn't agree more. Caitlin, your thoughts on real scenarios?
I
Anything
don't
you
have
want to call out?
specific real scenarios, but I think when we're having these conversations too, I'm not sure if we touched on this, but talking about quality of life. So if you do choose this path, what is your quality of life going to be after? Are you going to end up in a long-term care facility for the rest of your life? And what is that going to look like? If you do end up doing dialysis, what is that going to look like on a daily, weekly basis for you? And being very realistic, which is hard. It's very hard, but it's important, because sometimes people sign up for these things and then they didn't realize what that entailed. They didn't realize how their quality of life was going to change. So being very realistic and upfront about what it means if you are going to go down this path of aggressive treatment, or similarly, if you're not, and you're going to go with palliative care and hospice, how we can preserve the quality of life with palliative care and hospice care, and what that means to the patient specifically. And I also think touching on the anxiety piece and the health anxiety, which we deal with on a daily basis, is it's important to have a multidisciplinary team when possible, when having these palliative care conversations. So the nursing side, the social work side, the doctor side, having all of them together and having these conversations over a long period of time. So that's why it's important to get everybody involved. So, maybe the doctor starts the conversation, and the next week in the clinic, then the nurse touches on it and the social worker comes in, and having everybody's input on it so that the patient has more time to process.
Absolutely. If we connect the continuum, and I think then we'll sort of break for our Q&A because we're at 8:18, this goes to 8:30, but some wraparound thoughts. So I sit, in terms of my profession, I sit in an accountable care organization and a clinically integrated network. So it's multiple hospitals and individual practices. Let's say it's 250 practices, all specialties, all services. And there's so many initiatives going on. And obviously one of the key initiatives for any health institution is, readmission reduction and appropriate utilization, making sure that that ED visit was necessary, that patient couldn't have been diverted to another more appropriate level of care. And similarly with the admission, does this patient really need to be admitted? And so I can't help but wonder, if I comb through that, and we do really RCAs in different case studies, this topic of how would you like to live the rest of your remaining days? What do you know about your current health condition? Why do you think you keep coming to us for services and care? What is a need that isn't being met? These are all things that bubble up. And to me, as an RN, this is an opportunity that's just like folded in readmissions, but really it's an opportunity to build up a palliative care model within an inpatient setting, build up that stream of experts, the sexiness, if you will, of that service in and of itself, because of all the do good that it does for the institution, patients and family, and really colleagues across the board. So I'm curious to hear what your thoughts are. What is being done that you're aware of today in your environment of work that, looks at palliative care services and how to broaden them, or how to re-educate staff, how to sort of maybe like re-engineer it almost without taking away its core properties, so that it's more normalized, it's out there, and people are thinking about it and being more brave about it, and stepping towards their patients and not away from the conversation.
So I think the evidence base for the association between palliative care consultations and like hospital readmissions is mixed. It's stronger. The evidence is stronger among people with cancer, but among people with non-cancer conditions, it's mixed. And part of that is because of these conditions, are so hard to predict in terms of prognosis, right? So people have, periods of acute exacerbation, and then they have periods of recovery where they come back.
This is the
exactly
yes.
somewhat near to the baseline. That being said, there are efforts, and I can talk about one of the efforts at Yale with their health system, what they're doing to increase access to palliative care in part, but also reduce in-hospital mortality specifically. And so when patients arrive into the emergency department, clinicians are asked to answer the surprise question. And so the surprise question, for those of you who may not know, is the question is, would you be surprised if this patient died? Typically in the next year, but for Yale New Haven Hospital's purposes, it's within the last 6 months, in the next 6 months. So would you be surprised if this person died within the next 6 months? If the answer is no, I wouldn't be surprised if this person died within the next 6 months, then a screen, in the EHR pops up with options that the clinician can select. And one of those is consultation by palliative care. Another one is goals of care, is a trigger for a goals of care conversation. And so they're trialing this and seeing, if it does a surprise question result in less inpatient mortality, because the people that would screen no, I wouldn't be surprised, are then discharged presumably to VNA and palliative
to a different
care.
level of care.
Yeah, so that's just one example. There are a number of interventions that are being tested across the country to try and increase access to palliative care services. Some are have been more successful than others, but that's just one opportunity.
Can Yale's emergency room providers activate palliative care consults from the emergency room?
They can, yes. So it's particularly with this new intervention, they can order a palliative care consultation. Yes, absolutely.
Is that pretty timely? Does that happen pretty succinctly?
The goal is for it to be, yes. This initiative just launched in the end of May. So I think it is to be determined how.
That's such good timing.
How timely this will actually end up being. As I mentioned earlier, palliative care team members are finite. And so and some palliative care interventions can be provided by primary teams. So I think part of, while it's important to expand access to palliative care workforce, it's also duly important to train, non-palliative, non-specialist clinicians in providing palliative care interventions.
Absolutely. Okay, so I think what I'll do is I'll just quickly look at the chat. Mike, if you want to unmute to help me, I'm more than amenable to your assistance.
I just wanted to draw attention to one comment that was in the chat in relation to the last question you were talking about. But the very first comment was on how the palliative care team at this person's facility is now called the supportive oncology services. And that changes like the tone, which I actually really like that, because I think it sounds like there's probably just not as much association with like the palliative care name when you change the name. So I'd be curious to know, like, are the services the same? Is it the same kind of process and it's just truly a different name? Because I think that could be one of those things that makes a lot of changes for a lot of organizations. And I will say, like, in my own personal practice, I know the challenge of the nephrology practice that I'm in, they did try and create a fellowship that's a joint nephrology and palliative care fellowship that has had 0 applicants in the last 3 or 4 years, which also it kind of raises the point that, granted they're physicians and not nurse practitioners, but like the focus, even when it's available, is still not there, even in a practice that is truly dealing with terminal diagnoses on a daily basis, which is sad and just goes to show that there's a lot of room for growth in this area. And yeah, I think we just definitely have opportunity. I think it would be nice to see a lot more like joint fellowships for nurse practitioners available. I know, Shelli, you said there are a lot of palliative care options out there for fellowships. It might be nice to kind of join them with other things, like primary care residencies. You could see tackling on both fronts all at one time.
So some other questions. Shelli, maybe you can answer this one. It's a 2-part question. The second part is, A physician certifies the patient for hospice, then there is a hospice evaluation. Does hospice then have a role in accepting or denying that patient, or is the evaluation to assess what services are appropriate for them? Very good question.
So just so I understand, so a physician, so typically oftentimes it's the hospice attending or the hospice physician, the medical director of the hospice that certifies whether or not somebody's appropriate. And they take into account, a number of factors related to estimated prognosis, right? What's their admitting diagnosis? So what's the primary diagnosis that they're going to be coming into hospice for, whether it be cancer or heart failure or COPD, and then other factors as well, some of which I highlighted in slides. So, falls, hospitalizations, weight loss, cognitive decline, that sort of thing. So typically, if somebody is accepted into hospice, the attending physician at the hospice has already done the evaluation to determine that they are appropriate. Now, this is sort of the entry into home-based hospice, right? So hospice that's delivered into the person's home. This is different from inpatient hospice. There's a higher bar.
Yes,
there's a higher bar to reach for somebody who requires inpatient hospice. And that for entry into inpatient hospice, typically a person has to have significant, difficult to manage symptoms that can't be managed at home. Often these individuals have a prognosis of a week or less. Lengths of stay at inpatient hospice, or what they call GIP level of care, are often very short. And so when we're talking about hospice eligibility, the baseline is home hospice. So hospice care in the home or in the nursing home. Inpatient or GIP level care is much higher. They have to be, they have to have a much higher symptom burden to enter into inpatient hospice.
Like, just to clarify, they need morphine drip. What are you talking about?
Yeah, so typically they have symptoms
that come alive.
Yes, so they have symptoms that require parenteral medication. So parenteral opioids, they have, a lot of anxiety or agitation. They may be combative. They require, sometimes we'll get patients in inpatient hospice who have, VADs or other devices that require nursing support that we can still provide while in hospice. So that's typically, but typically they come in because they need some sort of parenteral symptom control.
Thank you. For newer providers in primary care, what would be the fastest, most straightforward way of learning within their catchment area who the key providers are for hospice and palliative care and how they can go about tracking that information? Anybody have tips on that? That's a question.
So typically palliative care is provided. So unfortunately, still most palliative care services are provided within inpatient settings, right? And so within your catchment area, you would look to the big hospitals, the academic medical centers, the cancer hospitals, because that's typically where the palliative care teams are housed. Oftentimes, they will also offer outpatient services. So, and they have ways to contact the palliative care team to inquire about, outpatient availability. That said, unfortunately, some palliative care teams still only offer outpatient services predominantly to people with cancer, right? So if it's somebody with, a non-cancer serious illness, they may not have access to outpatient services. It just depends on where you're living. Some hospices and VNAs offer home palliative care now. And so connecting somebody to the VNA, like your local VNA, they may also offer wraparound services. So they'll provide in-home palliative care services, which is very nice. And then in doing that, the intention there is they meet the patient early, they establish a relationship, and then as the person declines and their condition worsens, it's a natural transition to hospice. So I would suggest learning about what services are offered through your VNA, your local VNA, and home care agencies, as well as looking at, the hospital settings for palliative care.
I'll just add that I'm sure those entities would love getting your time and attention to pitch their business to you and what they can do for your patients. So I'm sure a phone call of interest could lend itself to a whole Q&A session. I know I've done that. Okay, I think we have somebody with their hands up, Catherine Dreyfus. Not sure if she can be unmuted or type in the question. I see a beautiful unicorn. Maybe she doesn't have a question. Okay.
That was a mistake.
Oh.
I didn't have a question, sorry.
Okay, no worries, no
Okay.
worries. Okay, a few other quick questions or notes. Caregivers dealing with a loved one that is advanced in dementia, Alzheimer's, or in a different diagnosis. How would you steer that caregiver in terms of reading material to help with the dying process or what to expect? How would you direct them in terms of resources to read? I think that's more the question.
So I think
This is
I'm happy
very
to answer.
wide. Yes, go
Yeah.
ahead.
So there's a couple, so not specifically for dementia, but there's a couple books that are good about sort of the dying process and in palliative care. So online resources, Get Palliative Care is a website that's patient facing, right? That's intended for patients and family members and caregivers about like how to get palliative care, right? The Center to Advance Palliative Care is the more policy arm that works to expand access to palliative care services. So those are like two online resources, right? Get Palliative Care and then the Center to Advance Palliative Care.
Mm-hmm.
In terms of books, so an older book that I do love is called How We Die by Sherwin Newland. It's a lovely book. It talks about how humans die from a number of conditions, not just cancer, but a number of conditions. So it's a great read. And then another book that I really like is When Breath Becomes Air by Paul Kalanithi. I may be butchering that last name, but that book, Dr. Kalanithi, actually the book was completed by his wife after he passed away, was diagnosed with a glioblast, I believe it was a glioblastoma. He was a neurosurgeon and talks about his, how he dealt with, the end of his life, and as I said, was completed posthumously by his wife. So those are some recommendations.
I would also say the American Association or the American College of Nursing has some courses too. There's a whole end of life nursing education consortium. So they have tons and tons of courses that are available. They have live courses that are available for providers. There's a lot of things out there on that website you can check out. Online things for continuing ed too. A lot of good things.
And did we say National Hospice and Palliative Care Organization for CAPC? I think that's another one.
Yeah.
Not okay. Okay, so I think we addressed most of the questions. Any last minute food for thought? Oh, somebody did write LNEC training, ELNEC training, question mark?
Yes, that's the end of life nursing education.
Okay.
Yeah.
Okay.
Yep, I would say LNEC is a fabulous resource for non-specialty providers who are interested in gaining additional education. They have opportunity or courses available for nurses as well as advanced practice nurses, oncology nurses. It's endorsed by the Hospice and Palliative Nurses Association, so it's a great resource.
Excellent. Well, I do realize we're a little bit over. We don't have any more questions. So I want to thank everyone for joining us today. I want to particularly thank all of our three panelists for their time and their expertise and their energy around this topic. I guess our main message to each and every one of you is stay curious, stay open, explore, push the boundaries, and be an advocate for this topic. All righty. Good night, everybody. Thank you so much. Thank you. Be well. Have a great summer.